there's a lot of diseases in the other chapters.
What's that?
A lot of diseases to memorize.
Diseases. I told you how to do that, right, last time?
No, like the paper that you gave us, it mentions few diseases, but then in the slides it mentions extra diseases, more details.
That's okay. That's, whatever questions I gave you, that's, the questions that I gave you. In fact, I've posted the answers for them as well, just now.
You did?
Yes.
The diseases that are mentioned in
I have the answers for you as well. So,
the diseases that are mentioned in the paper won't be in the test.
most of the questions that have been asked are the important diseases.
Oh, so
Yes.
the other ones won't be.
Yeah.
That makes sense.
Yeah, but kind of just look through them, okay? It's always good to know them, that's all. Because, you might come across something. So, okay, we just have to finish the very last bit about, we finished acquired immunity, both humoral and cell-mediated. And I told you about this combined chart that shows you how for any infection, you're going to see both acquired immunity, you're going to see both antibody-mediated immunity and cell-mediated immunity working together. Depending on the pathogen, sometimes one of them may be slightly more predominant than the other. But as you can see, the helper T cell is the one that is going to connect both antibody-mediated immunity and cell-mediated immunity because it has the ability to stimulate both sides. Okay, that's why it's called the helper T cell, and it plays a central role in immunity. Okay. Now, acquired immunity, as we all know, you only get it after birth. You're not born with it. Okay. So, what are the ways in which you can acquire immunity? Now, many decades back, the way a child would acquire immunity would be by getting the infection. They would get the infection and then.
Everyone got one? We're all good?
Did you bring it?
So, acquired immunity used to be naturally acquired. Okay. So, when we say naturally acquired, what does that mean? That means the person has to get the infection, suffer through the disease, and then once they recover, they have immunity against it. So, it is called naturally acquired immunity. Okay, naturally acquired. Active immunity. Active, why do you use the word active? Because the person has contracted the infection, suffered through the disease, and then memory cells are formed. So in future, they are protected. So this is called naturally acquired active immunity, where the individual has to suffer through the infection. Okay. Now, you also have, under this naturally acquired immunity, one is active. You can also acquire it passively. Passive immunity. What is passive immunity? Passive immunity is the passage of antibodies. So suppose somebody has antibodies towards a particular infection, you can just take those antibodies and give it to someone else for temporary protection. So naturally acquired active immunity provides a longer protection, whereas this is more short term. Okay, this is more temporary. So, what is passive immunity? Passage of antibodies or transfer of antibodies. An example of that would be transfer of antibodies from the mother to the fetus when she is pregnant, or transfer of antibodies from the mother to the newborn child through breast milk. Okay, so you know that newborn children are not going to have acquired immunity because they haven't been exposed to any pathogens. So the initial 6 months of life, it's very important for the infant to be protected by maternal antibodies. So whatever the mother has, IgG antibodies against infections that she has encountered, it can pass, because you know IgG antibodies can pass through the placenta. So they can pass through the placenta and offer short-term protection for the fetus. So that is how a newborn infant is able to survive. So passive immunity is passage of antibodies. Antibodies from mother to fetus. Mother to fetus through placenta, this is via placenta, or from mother to fetus, mother to newborn through milk, breast milk. So that's why breastfeeding is so important, because it actually provides a lot of important substances for the newborn fetus. So that is naturally acquired. However, nowadays, this is not so common. Naturally acquired active immunity is not so common because we have come up with vaccines. Okay? So artificially acquired. So that is naturally acquired. This is artificially acquired immunity. When we say artificially acquired, again, there are two components to this: active immunity, artificially acquired active immunity, or artificially acquired passive immunity. So when we say active immunity, this is the immunity that you get by vaccines, through vaccines. So nowadays, if you take the early 20th century, you will see that a lot of deaths were due to infectious diseases. Children would not survive for more than about 8 or 10 years because they would get diphtheria or polio or, all kinds of infectious diseases. Chickenpox, measles would cause death. Now there has been a drastic drop in the infant mortality rate because of the vaccines. Okay? So artificially acquired active immunity is through vaccines. Okay? This is through vaccines. Administering vaccines during the initial stages of life. So we'll talk about some vaccines. And then you also have artificially acquired passive immunity. Again, when I say passive, it is always antibodies. So this is injecting antibodies into a person. Okay, injection of antibodies. So here it is natural passive immunity because the mother is passing it on to her fetus or newborn through her secretions. Whereas here you're injecting antibodies to protect someone. Okay? So injection of immune globulin. Gamma globulin is antibodies. Okay? So this we use a lot. Okay? For example, even during the pandemic, you would have seen that there was people who were severely suffering from COVID, were treated with plasma, were treated with antibodies that was acquired from individuals who had recovered from COVID. Okay, so they were giving them antibodies just to help them out because they were severely disadvantaged. So you can inject antibodies for, this is again temporary, it gives short term. Okay, it's not a permanent solution. Okay. So you can have, for example, when you give tetanus toxoid after an injury, if you give tetanus toxoid, you take a tetanus shot, that is actually just antitoxin that you're taking. Or if an animal bites you, the rabies vaccine that you take is giving you temporary protection because it has the antibodies. That's all. It doesn't have anything else. It's not going to give permanent protection like vaccines. Okay? Those are the ways in which you can acquire immunity. So just to give an example, like I've had chicken pox when I was young, I've had measles. So the way I have my acquired immunity for these infections is naturally acquired active immunity because I did suffer through the infection. Whereas those born later, most of you may have artificially acquired active immunity because you got the vaccine. Okay? So vaccines, what do vaccines contain? Okay. Now vaccines basically contain either dead, killed antigens, that is dead pathogens, or live attenuated antigens. Attenuated means weakened. So they are not as virulent enough to cause disease. So their potency to cause disease is weakened by doing some tweaking in the lab. Okay? So you take the pathogen, you completely kill it, that is called a killed vaccine. Okay? Or live attenuated vaccine. So if you look, and nowadays we have different types of vaccines. So this is just for your own knowledge. Okay. So you have inactivated, killed vaccines. So here the pathogen is completely killed. Okay, but even the killed pathogen is adequate enough to cause your immune system to produce a response. Okay, so you do have example of this is we do have an injectable polio vaccine. Which is still in use. Okay, especially in the US they use this. Injectable polio vaccine, IPV. They use this for killed vaccine. The other more common one that is used is live attenuated vaccine. Live attenuated vaccines. Now this one includes all your chicken pox vaccine, MMR, oral polio vaccine, rotavirus, I think, yeah. All these are live attenuated vaccines. Killed vaccine, there should be something else, I can't remember. Killed. I think hepatitis A is also killed vaccine, I think. Is killed. The third type, these were what were available before. And over the last 3 decades or so, many new ones have come up. We have what is called subunit vaccines. Subunit vaccines is where you don't even need to have the entire pathogen. you just take a small piece of a capsule protein or maybe a cell wall protein and then you inject it. So you don't need the whole pathogen at all. You just take a piece of the pathogen and make a vaccine out of that and inject it, and that is sufficient to trigger your immune system to learn how to attack that. So hepatitis B is like that. It's a subunit vaccine. Hepatitis B, and I think HPV is also the same. Human papilloma virus vaccine is also a subunit vaccine. Then you have, what is that? Polysaccharide vaccines, where you use the capsule. You use a capsule protein to polysaccharide vaccine. So you use a capsule protein, the capsule of the bacteria. You can use that to trigger the immune system. So here it's because using the capsule protein. So I think this one, most of the vaccines for meningitis, pneumococcal meningitis, meningococcal meningitis, those are polysaccharide vaccines. Meningitis. Okay, I think mostly bacterial meningitis. Bacterial meningitis. And then comes the more newer ones, the messenger RNA vaccines, mRNA vaccine, with the first one for human use, the COVID vaccine. That is an mRNA vaccine. So you're actually using a messenger RNA, injecting a messenger RNA, and then this messenger RNA will be translated into a protein, viral protein, by your body cells, and then your immune system learns how to make the antibodies against it. So mRNA vaccines, COVID is one which is used. And the last one is DNA vaccines. So they are also trying this. DNA vaccines are where you use a small piece of DNA to trigger DNA of the, you don't use the whole DNA of the pathogen, you use a piece of DNA of the pathogen to trigger the immune system. Okay, so DNA vaccines have been in use for animals for a long time. So we have dog vaccines, fish vaccines, horses, equine vaccines, cattle, pigs. So DNA vaccines for animals are available, okay, for quite some time. And these are like, fish vaccines and is used by people who have the, who grow fishes as an industry, the fish industry. For salmons and different kinds of fishes, they have vaccines. Okay. But human vaccines, not yet. It's still in trial. So they are actually for humans. What they are trying, clinical trials are still going on. It's not in use. So this is going on for Zika virus. The DNA vaccine for this is ongoing. And then they are trying for HIV. They are trying for, I think, influenza also, DNA vaccine. HIV, influenza, something else as well. I forgot. Okay, so those are, this is not yet available for us. So vaccine, the thing is about, we have learned about epidemiology, vaccines, how herd immunity is important in order to protect those who cannot be vaccinated. But increasingly, you're seeing a lot of people being against vaccines. One of the reasons is that there is fear about trusting some of the scientific companies, the pharmaceutical companies, and trusting scientific evidence. Okay, so there's a lot of fear there, and of course miscommunication. People don't understand the science well. But the most important thing that is doing a big, disservice to this is the single study that came from UK, okay, in the 1980s, late 1980s. This was a study that was done on children, and the physician was one Dr. Andrew Wakefield, and he studied 12 children. Okay, the number was very small, just 12. And he linked the MMR vaccine to potential autism. Okay, MMR to autism. He just studied 12. He said there is a potential of the MMR vaccine causing autism. Okay, and this was published in the Lancet, okay, a prestigious journal, which then withdrew that study because it was shown that obviously the numbers are too small. When you do clinical trials and all, you have to have larger numbers. Secondly, it was a false study. The data was cooked up. It was manipulated to show that MMR can cause autism. And thirdly, there was some bias as well, because this doctor was being paid by the pharmaceutical companies to, sort of disprove this MMR, because the doctor himself was coming up with another vaccine. He was trying to promote his vaccine by trying to discredit MMR. So if you read through that, Andrew Wakefield, it's a huge thing. But this happened many decades ago. But unfortunately, if you just if you go put in a search bar, if you put in the word vaccine denial or vaccination, adverse effects, the first thing that will pop up is this one, Andrew Wakefield's theory, and his paper will pop up. So this man has already been, blacklisted. His name has been taken off. All of that has happened. He can no longer practice. But then that particular study still is making the rounds. And so people are fearful of vaccinations. They are not willing to look at studies which show that because of vaccines, childhood infectious diseases have declined to such a large extent. You're not even aware, because those born over the last 15, 20 years probably have never seen a case of chickenpox, have never seen measles, mumps, nothing. Why? Because of this. Okay? So that's the sad part. Yes.
If you all ever find yourself in an argument with anybody about whether or not vaccines...
Now, the last one is allergic reactions. Okay, last in immunity is allergic reactions. Now, allergic reactions are also reactions of your immune system. It is your immune system trying to protect your body, but unfortunately, the protection ends up being harmful. So it is not a beneficial response of the immune system. Okay, it ends up being a harmful response. So in allergic reactions, the immune system tends to attack an inanimate substance, that is a non-living substance. So this substance is not a pathogen, it's not going to harm the body, it's not going to invade the tissues, but somehow the immune system thinks that it is a pathogen and foreign antigen and needs to fight it. So allergic responses tend to be more harmful than beneficial, and a simple allergic reaction is just itching, redness, tearing of the eyes, maybe nasal congestion, okay? But then sometimes it can be severe as well, leading to almost sometimes death of the individual. So it can cause swelling of all your mucous membranes, your passages. So not just nasal congestion, but even your throat, your air passages may congest. And then it will block the passage of air. So that it can cause respiratory failure. And then sometimes it can also cause dilation of your blood vessels, severe drop in heart rate, drop in blood pressure, which can all lead to, it can be fatal. The person may become unconscious, heart can stop beating. Okay? So all of these reactions, you know, they are not against a pathogen, but they are directed against a harmless substance like pollen, dust, okay, some other material which is contact dermatitis. So these kind of things. Okay. So in allergic reactions, what does happen is this. So a person is exposed to the allergen. So let's say you have allergy to pollen, which started maybe 2 years back. Okay, before that you were fine. But that doesn't mean that 2 years back when you experience that allergic reaction, that is when things started. Over a period of many years, your body gets sensitized to the allergen. So initially, you are exposed to the allergen, let's say dust or pollen. So this enters into your body, you breathe it in, it binds to some of your proteins that are there in the blood or in the tissues, and then it becomes an antigen. So it's a hapten. Initially, it's an inactive substance. It's a hapten. But once it gets into your body, it binds to some of the proteins and then starts behaving like an antigen. So this antigen will be, this pollen will be recognized by your B cell receptors. And the B cells will start making a lot of IgE antibodies. Okay, they'll start secreting, they'll get converted to plasma cells, and they'll start secreting IgE antibodies. Okay. Now these IgE antibodies, what they will do is, they will go and bind themselves to the white blood cells which are resident in your tissues, the basophils. I told you basophils, once they enter into the tissues, you call them mast cells. So these IgE antibodies will attach themselves to these mast cells, okay, and they will stay in the tissue. So this will happen over a period of few years. And then all of a sudden, the next year, when you are exposed to that same antigen, the pollen, now these tissue mast cells which are already there and prepped up, they have the IgE antibodies to recognize that hapten, they will bind to the allergen. And once they bind to the allergen, these mast cells are going to break open and they will release histamine and all kinds of chemicals, a major being histamine. They will release a lot of histamine. And histamine is responsible for all the symptoms that you have. Redness, itching, swelling, rashes, all of that is due to histamine. Okay? And if this happens with a lot of mast cells, if many mast cells break open, a lot of histamine is released and it can cause difficulty in breathing, drop in blood pressure, and maybe even require hospitalization for something trivial like allergic response. So, and that's the reason why when you have symptoms like this, you take an antihistamine. You take, you take Allegra or you take Zyrtec. All of those are antihistamines, okay, because they reduce this. So there are many different types of allergic responses. Even, so you see this one. This is very common. We have all experienced this in some form or the other. Okay, you've experienced asthma. Many people have difficulty in breathing if they are exposed to dust. So we've all experienced this. Or when you come in contact with poison ivy. So those are all different types of allergic reactions. There are about 4 different subtypes. Okay, type 1, type 2, type 3, type 4. Hypersensitivity reactions. So this is another name for allergic reactions. Allergic reactions is what you commonly term it. The medical term is anaphylaxis. Anaphylaxis. Phylaxis means protection. Ana means opposite. No protection. Okay, anaphylaxis. So there's a type 1 anaphylaxis, type 2, type 3, type 4 anaphylaxis. So poison ivy, asthma, contact dermatitis. So many people are allergic to certain types of material. Some people are allergic to metals, like they can only wear gold or silver, they can't wear other metals. So contact dermatitis is an example of an anaphylactic reaction, okay? And blood transfusion reactions. So when you give the wrong type of blood, a blood transfusion reaction is also an example of an allergic reaction. Okay, blood type, you have to match the blood type. So if you give the wrong blood type, that reaction is also an anaphylactic reaction. Have you heard of this one? Have you heard of this test called tuberculin test?
Yeah.
Have you heard of this? The TB, yes, for tuberculosis. So what do they do?
It's just like a little needle they put intravenous. It's not intravenous, it's
Not intravenous,
it's dermal.
dermal, subdermal.
Yeah. And they just put like the bubble and they see if it like stays for 72 hours, I think.
Yes, so they actually inject a piece of the tuberculous bacterium. Okay, they inject it under the skin, and then they ask you to wait for about 24 to 48 hours, and then they see whether you have a rash or a swelling. They measure the diameter of the rash. So that is also a part of this type of reaction. So if you have been exposed to the tuberculosis bacteria, maybe sometime, some years before, or even if you are having an active infection going on, you will see after the injection, you will see that that rash will be pretty big. So it has to be beyond a particular diameter, so they measure it. If it is bigger than that, that means you are currently having a tuberculosis infection, or maybe you have been exposed to it many years back, okay? And it will give a positive reaction because there are antibodies in your blood, okay? If it doesn't go to the required size, that means you have not been exposed to the tuberculous bacterium, okay? So these are all part of this anaphylactic test. So allergy is that. Even drug allergy, okay? Allergy to drugs like penicillin. Okay, penicillin. So there have been cases where, and I myself have seen that. So penicillin is an excellent antibiotic. It's an excellent antibiotic, especially for syphilis. It is one of the best. We still use penicillin. And many a times we have to give penicillin by injection, intramuscular injection. So there have been times when, because when you are in a country where there is illiteracy, many people don't know what they are allergic to. They won't even know, are you allergic to any drugs? They won't know. So when you give penicillin, and as you're pushing the plunger in, we give at least about a few ml of penicillin has to be injected. So as you push the plunger, maybe a small little bit goes in, immediately the patient will drop unconscious. That is like very quick reaction, very quick allergic reaction. And you can lose a patient. You can lose a patient because of that. Okay, within a few minutes, you can lose a patient. So sometimes these reactions are very severe.
So what would you do? Would you do like a skin test prior if they don't know they're...
Yeah, you normally can give a little bit and see what happens, but you have to be very careful. Sometimes, especially in places like India where we used to have, we would see thousands of patients in a general hospital, the outpatient. there's no time for most of these things. So sometimes patients end up, have to put them in the ICU because of that. And most of them are illiterate. They don't know what they're in for. Yeah, but you don't see so much of that in developed very quickly, okay? Now, there are a lot of statistics here, which, that is just for your interest. That's all. So HIV, as you know, human immunodeficiency virus and AIDS, okay? So this is a retrovirus. So, and AIDS is acquired immune. So now you understand, acquired, because we have learned about acquired immunity. So this is an acquired immunodeficiency syndrome. That means acquired immunity is not working well. It is deficient, okay? So the cells that the HIV virus targets is the helper T cells, which are called the CD4 plus cells. So this is the cell it targets. So the virus enters into the CD4 cells and remains there. It multiplies there, okay? And then untreated, if the infection is not treated, then the number of these helper T cells will start to decline, and that's when the individual will go into this disease. And they die not because of the HIV virus itself, they die because there are opportunistic infections. Because the acquired immune system is not working well, all other kinds of infections come in, cancers develop, and so the patient dies within about a year or so of landing with that disease, with that syndrome, okay? So that's the last stage of the infection. So again, these are, it was recognized in the US in the early 1980s when there was a cluster of patients who died because of getting a fungal pneumonia. Remember, I told you fungal infections of internal body organs is very rare, because unless you are severely immunocompromised, fungal infections of the skin are very common, but the internal organs not so much, because your immune system is good. But they found a cluster of patients who died because of getting this fungal infection, pneumocystis, that is the genus, pneumocystis pneumonia. Okay, and once fungal infection, we don't have very good medications for internal fungal infections. So they died because of that, and there was another cluster of patients who got a type of soft tissue cancer, which is called Kaposi's sarcoma. So they found these cases, and at that time, this was first seen in homosexual men. So there was a cluster of cases. That's when they started looking into it, and it was only in 1983 that the pathogen was isolated. Okay, but this is in the US here. Okay, but it started somewhere in the 1960s. So the theory is that the virus jumped from chimpanzees to humans. Okay, sometime in that. So this is called the simian immunodeficiency virus, simian for chimpanzees, and it sort of jumped from chimpanzees to humans because of the practice of eating bush meat or coming in contact, killing these animals and coming in contact with the blood of these animals, or eating of bush meat. So that's when they think that transmission should have happened. So and then from there it spread, and into the US, I think somewhere in 1970, 71. So the first known case in the Western world was a Norwegian sailor who died. And then sometime in late 1970s, early 1980, we saw cases in the US. Okay? And worldwide, the statistics is pretty high, although now it is declining. Okay? So with better, not because of better treatment measures, but better, diagnostic features. People are being diagnosed earlier. And so you can see a lot of worldwide, United States, we still have about 1.2 million people living with HIV. Okay, and also 1 in 8 of these people are unaware that they are infected. Okay, that's the beauty of these viral infections. So you may not know that a person is infected unless they go for the specific test, because it doesn't cause any symptoms. Okay, and here in the United States, we still have quite a number of people. You see, out of this total 1.2, about only 66% of them have actual access to therapy for HIV, viral therapy. Worldwide, that is even less, because these medicines are very expensive, very, very expensive. So it's difficult for developing nations to actually provide this kind of treatment. Okay? And it's one of the 8th leading causes of death. So we will skip all this. Okay? So this was what, this is how it was. This is a 2015 statistics, not so almost 10 years old, but pretty much similar. Okay, so you see that by race and ethnicity, about African Americans are the most vulnerable to this. And 2014, male-to-male contact is what is the form of transmission. But heterosexual contact is also increasing now. That is, the male partners passing it on to their female partners. This is also increasing these days. This was a very small percentage before, but now this has increased. Okay, okay, so we'll skip some of these things. Okay, so by race. Okay, so this is a single-stranded RNA virus. It's a reverse transcriptase virus. Reverse transcriptase, that means it has, because it's an RNA virus, the RNA has to be converted to DNA, okay, inside the human cells. So that's why the enzyme that is needed is reverse transcriptase. Okay, and so HIV-1 and HIV-2. HIV-1 is the one that is causing the infections. HIV-2 has still not, it hasn't come from chimps to humans. It's still HIV-1 that is the main cause of our infections in humans. So this is how the virus looks like. It has 2 copies of that RNA, okay, and then it has the capsid, the protein, capsid protein, and then it comes with 3 key enzymes. The 3 key enzymes are reverse transcriptase, protease, and integrase. Okay, we'll see what this does. Integrase, protease, and reverse transcriptase, these are the 3 key enzymes, and the medicines that we have for HIV target these enzymes. We have anti-protease, anti-integrase, anti-reverse transcriptase medications which are used for HIV. Now, the envelope, these are enveloped viruses. So there is an envelope with spike proteins, and this spike is of importance. Okay, this spike is of importance. This is important for the virus to get into the host cell. So you see the spike. This is a glycoprotein spike. That is, it is made up of sugar and protein. The globular part of the protein is called GP120, and then this is GP41. Okay, so these are glycoprotein spikes. And the way the virus enters into the humans is like this, into the T cells, helper T cells. So the helper T cell has the CD4 receptor. Okay, you know that I told you helper T cells, immunologists will refer to it as CD4 cells. They won't call it T helper cells. The receptor on the helper T cell is called the CD4 receptor. Now this glycoprotein 120 goes and nicely fits into that receptor. Okay, it goes and fits into it. And then the T helper cells have another co-receptor. This is called a co-receptor. Okay, so this is the main receptor, CD4. This is called a co-receptor, CCR5 or XCR4. This is a co-receptor. Don't worry about the name, but it's a co-receptor. Now, this co-receptor is like a hook. So, it will go and attach itself to the GP41. And this is how the virus attaches itself to the T helper cell. So, it cannot attach to any other cell in the body, only the T helper cell, because it has this specific CD4 receptor and this specific co-receptor. Now, this co-receptor is of interest. Why am I telling you this? Because if you look at the human population, there is a 5% of the population has T helper cells that do not have this co-receptor. Okay, it's a natural thing that you see in 5% of the population. They don't have this co-receptor. And because they don't have the co-receptor, these people do not get infected with HIV. Okay, so they are immune to HIV. That has been found. So now the research is, can we somehow get rid of this one? They're trying to see whether you can block this CCR5, and then the virus will not be able to attack the helper T cells. So this is what they have seen in a small percentage of the population. They have noticed this, that they don't have the CCR5. And so they are immune to HIV. Even if they are exposed to HIV, they don't get infected. Yes? Now, in active infection, okay, we'll talk about the phases of HIV. So once the T helper cell gets infected, the viral RNA gets converted to DNA, and then it becomes part of the DNA of the T helper cell. And then every time this DNA is getting copied, the virus can also get copied, and then the DNA can be converted back to RNA, and then all the envelope and everything can be made, and then the virus slowly doesn't destroy the cell, it slowly exits the cell. Okay, slow release without damaging the T helper cell. And this virus will go and attack, it will get into another T helper cell. So this is how the virus sort of slowly progresses. Okay. And here you have a picture of a macrophage. So it can also enter into macrophages and it can multiply, the same thing. So T helper cell as well as macrophages, because a macrophage will phagocytose the virus. It will phagocytose the virus, and the same thing can happen even in macrophage cells. So let's look at the phases, okay? So stage 1 is, there are 3 stages to HIV. Stage 1 is the acute HIV infection. This is generally missed, okay? The person will have a flu-like illness, and maybe some lymph nodes may enlarge, but other than that, no other symptoms. So like my fever and that kind of muscle aches, that's all. And at this time, if the person is tested, there will be lots of viruses in the blood in the acute phase, okay, in stage 1. But this stage 1 only lasts for maybe a week or 2. That's it. It doesn't last for a long time. And this is a very contagious period, and the viruses are found in the blood, and then they immediately enter into the CD4, the helper cells. They enter inside. So this is a short period. If a person suspects that they have had unprotected sex and they think they may be infected, they should go and test themselves. Only then you'll be able to see this. Otherwise, it gets missed. Okay, you can miss this stage. And think of it, can be taken as any kind of mild flu. That's it. Stage 2, this is the latent period. Okay, the clinical latency, stage 2. This can go on for years. This is usually years, 5 years, 10 years, or even more. Okay, so this is what is chronic HIV infection, where the virus is going to go and become part of the DNA of the T helper cells. And it's going to maybe quietly multiply like that. Not very active. A few viruses being made every day, and then they go and sit inside another T helper cell. So they may remain latent like this.
So it's a persistent infection?
This is persistent, yes. This is the chronic stage. Okay, but at this time there are no symptoms. Again, the person is completely normal, but can pass on the virus to their partners, and they have absolutely no symptoms. You will not find any viruses in the blood as well, so blood tests may not reveal any viruses. Okay, but this can last for a long time, and if they are not treated, it's going to slowly spread. Okay, but can still transmit HIV to others. Okay? And then towards the end of this stage, which could be in 5 years or 10 years or 15 years, nobody knows, towards the end of this stage, suddenly the virus numbers will start increasing. Okay? So you will see, if you're following the patient, then you will see the viral load will start going up, and a lot of CD4 T helper cells will start getting destroyed. So they'll start getting lysed. Okay? And that's when the number of T helper cell, the numbers will start steadily going down. And then the person enters the stage 3, which is the AIDS, acquired immune deficiency. This is the severe phase of HIV infection, where you're going to have, you take a blood sample, you're going to see a high viral load, very high viral load, very contagious period, and the CD4 cell count, that is the helper T cell count, should become less than 200 cells in every microliter of blood. Microliter is 1 drop. 1 drop of blood is a microliter. If you prick your finger and get a drop, that is a microliter. So every drop of blood should have less than 200 helper cells. The normal number is almost 1000. Every drop should have 1000 T helper cells. So this is the cutoff point. The moment they do a CD4 count and see that the numbers are less than 200, they know that the person has gone into AIDS. And by this time, the patient will also have symptoms. There are lots of things that indicate that the person has gone into phase 3, which is the active infection. So lots of bacterial infection. They'll keep coming back with pneumonia, fungal pneumonia that I told you, pneumocystis, fungal infections of the respiratory system. They may get tuberculosis. They may get cancer, soft tissue cancer. Women can get cervical cancer, and then all kinds of other viral infections. Okay, things that normally do not happen if the immune system is healthy. Okay.
So they're also like the cancer of the tumor of the jaw?
Yes, that tumor of the jaw, that's soft tissue tumors. So they can have skin, blood vessels, different types of cancer, because now the immune system is not working. Okay? Because the T helper cell is the central one. So once that goes away, your antibody-mediated immunity doesn't work, cell-mediated immunity doesn't work. Yes?
What's more common is pneumonia and the pneumonia and the cancer when people face?
The pneumocystis. This is the fungus. This is the commonest, pneumocystis, and Kaposi's sarcoma. This is what you see very often in patients. Okay, now can HIV be transmitted? Yes, absolutely. HIV can, obviously it's a virus, it has to enter into a host cell, but it can survive for roughly 6 hours. So when it travels through the blood, it can remain for 6 hours without any problem, and then it can infect a cell. Okay. Now, primary reason for transmission is sexual contact. Okay, body fluid contact has to be there. It can be, the virus can be transmitted through breast milk as well, from the mother to the newborn infant. It can be transmitted through the placenta as well. Contaminated needles, so drug pushers, drug users. Organ transplant, if you do a transplant without checking. There is possibility of HIV transmission through a bone marrow transplant or a liver transplant. You can have that. Artificial insemination, if semen is introduced and it's not checked, blood transfusion can do that, okay? And of course, anal intercourse, okay, which is what you see in, this was the first thing. It was noticed in homosexual women, men, so it was, so this is another, just contact with the person, hugging or shaking hands with the person doesn't cause any transmission. And saliva also doesn't. So kissing doesn't cause transmission of HIV because saliva seems to have very few viruses. So the virus doesn't seem to be expressed in saliva. But you find it in all other bodily secretions, okay, mostly vaginal secretions, anal, semen. You find it in all of that, breast milk. These are all. Okay, so there have been a lot of cases where you see that, some people are not infected at all. So, like I said, people who have this mutation, they don't have that co-receptor, they don't seem to get infected. And they have also seen that there are certain populations of people who somehow seem to survive without having active infection. Okay, they're trying to study what it could be that is making these people survive. They are HIV positive, but they don't seem to progress to the chronic stage. Okay, so they have very low viral levels, and they don't seem to go into the phase 3 at all. Okay, long-term non-progressors. And they think that all of this could be because these individuals have really good cytotoxic T cells, which are capable of seeing the infected cells and getting rid of the virus. So there is still research going on. They've also seen a population of sex workers, women sex workers in one of the African countries where these sex workers are exposed to HIV, but somehow they don't get infected at all, even though they have had sexual partners with HIV. So they're trying to look at all this because we still are not sure how to control HIV. Okay, we don't have any, we have good drugs, but then we don't have a vaccine for HIV because the virus mutates very quickly. So it's very difficult to come up with a vaccine. Now there are lots of medications available, good medications available. You can test for HIV by looking for antibodies, or you can take a sample of blood and look directly for the viral nucleic acid. So we can do PCR and look for it. So prevention is somehow the most effective one so far, since we don't have anything to completely, we don't have a vaccine yet. So they are trying to encourage safe sex practices. Even drug users are being supplied sterile needles by the county in order to make sure that they don't use used needles. And if a person is about to have sex that is going to be unprotected, not known, there is something called pre-exposure prophylaxis. So a medicine can be taken before sexual encounter or after an unprotected sexual encounter, post-exposure prophylaxis. So these are some medications that are usually supplied by the county itself, okay, to make sure that people are aware. So you can take it before an unprotected sex or after. Yes, these are antiviral medications. Like I said, you have integrase inhibitors, protease inhibitors, lots of different medicines are available, but these are expensive. These are expensive. Not very easily available, especially in developing countries where the incidence of HIV is high, okay? So, but there are a lot of organizations that are working towards this. So even here in the US, these medications are available, so the numbers are coming down. But places like Africa, India, the numbers are actually rising because lack of availability of these medicines. Okay, so it is very difficult to come up with vaccines because we don't have an animal model for this kind of a disease, to mimic this kind of a disease. For diabetes and things like that, we have mice, which we can make the mice diabetic. But we don't have an animal model for this.
Can't they use the monkey, the HIV?
Yeah, they do use, yeah. But monkey, experimental animals, when you have to buy them, buying a mice or a guinea pig is cheaper compared to when you use bigger animals, larger animals.
And it comes down to humane practices.
Exactly. There are so many ethical practices that you have to follow. So those are those are challenges. It's not that it's not happening. Research is happening, but those are challenges. And as I told you, very high mutation rate. So it's difficult to come up with an ideal vaccine. If you have one pathogen which is going to look the same, yes, you can make a vaccine towards it. But this virus keeps on changing itself. So within a single individual, you have multiple variants. So how do you give a vaccine? Okay. So they are looking at other things. They are, like I said, DNA vaccine for HIV. Their research is going on, but we are not anywhere close to that. Okay. So that's about HIV. And if you're interested in reading books, I don't know whether you have heard of this book. It's an old book, The Tennis Partner. Have you read that? Anybody? No? The Tennis Partner. It's an old book. It's written by one of my, a physician who is attached to Stanford Medical School. And he's actually one of our seniors. He studied in the same medical school in India like I did. So that's the only thing that I can talk about. But The Tennis Partner. So this was about, I think he came to the US around the 1980s when HIV was going on. So if I remember right, this is a true story, I think. I think it's a true story. The author is Dr. Abraham Verghese. It's a pretty good book. It talks about HIV and things like that. Okay, so that is about this. So we are done.
Wow.
Done. 15 weeks, okay? Now, for your, you already know about the exam, right?
Mm-hmm.
I'm going to post that open book 40 points today. By tonight, I'll post it, okay? So that's that's on the diseases. Now, I've given you a sheet with the questions for the diseases, right? I have actually posted the answers, like you asked me. I posted the answers just this afternoon. So the answers are there, okay? So, and the other day when we were talking about it, students were asking, so the best thing would be, now the questions that you have in that sheet and the answers that are provided, for microbial diseases, I know it's not easy to remember all these names, but I have only picked some of the important diseases that you see on a day-to-day routine practice. You will see those diseases, and they are some of the important ones for this geographical region of the world. So you see these cases. So there are many other parasitic diseases which are not seen in the US, so I have not included that. So most of them are things that you see here. So the best way to study that would be, of course, you can answer those questions. I already have the answers. You can come up with a table. You write the name of the disease, the causative organism, and then you have the most important signs and symptoms, or what are the features, okay? And of course, I don't want you to know the treatment. So just make a table, diseases of the skin and the eyes, based on the questions that I've asked. You can just make a table. Same thing for cardiovascular, same thing for GI tract, digestive system. You can do that. It's not going to be that difficult. Of course, it requires some memorization. You have to remember. But I don't think it should be that difficult. You know, and the PowerPoints have a lot of information about each of those diseases. And I have audio files as well, okay? So what
Where did you post the answers to the questions?
under the same thing, it's right under the questions. It's right under the questions with answers.
Under the review questions on microbial diseases.
Yep. Okay, so what I would like to do is, I mean, I'm always aware, I'm here, so if you want to ask questions or you want me to go through any of those questions, we can do it in the lab. But for those of you who think that you can manage with the answers and the audio files, we don't need to have the lab today. Okay, I'm not going to take attendance, so if you want to be there, you can be there if you have questions. If not, you can leave, okay? And I'll see you on Tuesday.
Wait, are we gonna have like a review session before the test?
Tuesday the 16th at 2 o'clock is your test, okay? So what time do you want?
Can we do it at like Zoom again?
You want to do Zoom on Tuesday?
Or maybe like the Monday, something like that. Like
Or you want to have a Zoom session on Monday?
yeah, before 9, so we can.
Oh, okay, so you just want to come here at 2.
Yeah. I think the
What do you want? You tell me.
the Zoom with the.
You tell me when and the time.
Should we do it at like the same time as before? I think at like 6 p.m.
It's up to you. It's up to you. You tell me and then I will. What time? Or you want it at 1 o'clock here, that's also fine.
At 1 o'clock on Tuesday next week?
That's fine, I'm here on that day, but
So regardless, you'll be here at 1 o'clock.
I'm here in the morning itself, so.
She always has a recording.
I also wanted to ask,
We can have it
I
at
know
different
there's
times.
stuff under immunity of review questions about that, but some of those review questions were in the packet you gave us.
Yes.
So, are those like, did you combine and like pare down the questions when you gave us the packet, or? do
The
you want us to
microbial
do both?
diseases?
No, some of the microbial disease questions were the same as the immunity questions.
Because immunity, we talked about HIV and also, that's
Okay,
why.
so it's
Only
just
that HIV is sort of, you see it in both.
Yeah.
Other than that, I think it's separate. You have to tell me, I'm here at 1 o'clock on Tuesday, I can have it on Tuesday. Or if you, but I can't do it both days, okay? Don't ask me to do it on Monday evening and again on Tuesday, no.
Wait, sorry, I kind of like it on Zoom though.
Zoom on Monday.
See, I know, see, so many people. Somebody wants it in Monday Zoom, somebody wants Tuesday afternoon.
It doesn't matter what day or time it is because you'll watch the recording, so it doesn't matter, right? So if you can't go, then just watch the recording. Sorry. Can you do a poll? Or I'll do a poll. Just watch the recording, yeah.
Okay. Huh?
Wait, so what's the conclusion?
It's up to you.
Zoom on Monday, yeah, I'm down.
6 p.m.?
Yeah.
Alright.
What time do you
I
want?
think 6 people get off at work at 6. What about like 7?
What time?
You guys have night shifts? Never mind.
Okay, 6 or 7?
Yes, quick.
Sorry, I'm a middle school teacher.
And you do know I have a life as well outside of this class and course and campus, okay? I do have a life and I have things to do as well. Yes, oh, that's very sweet. Yes, you are my life, that's true. But then I do have another life also, which I have to.
What time works for you, Professor?
Whatever time you tell me, I will try to free up that time. That's what I'm going to do. Because Monday I have an exam early in the morning. They have an 8 o'clock exam.
Does 6 work with you?
Okay, yeah. 6 o'clock on the 15th, Zoom.
Yeah, 6 will work.
Okay.
Okay.
I'll probably have to take
7
6
might be
lunch.
a 7 might be a little difficult because I have something else. That is a Monday, right? 6 will work, yeah, 6 will work.